Hello and welcome to Digest This, where we focus on day-to-day clinical issues in gastroenterology. I'm Elaine Robertson, a gastroenterology trainee in the west of Scotland. Today the focus is on hepatitis C. I'm delighted to welcome Professor John Dillon, a Professor of Gastroenterology and Hepatology here at the University of Dundee. Professor Dillon has an interest in blood-borne viruses, both in the clinical and in the research setting, and is well placed to update us on this topic today. Welcome, Prof. Dillon, and thank you for taking the time to join us.
Thank you, and thank you for the invitation. It's my pleasure.
So, hepatitis C has had a global health impact. Can you give us an idea of rates of infection worldwide?
Yes, so if we start from the Scottish perspective, about 1% of our population are antibody positive, about 0.7% are PCR positive, and PCR positive for the HCV RNA means they have active infection. And if we think about PCR positivity across the world, if you go into Southern Europe, the rate goes up to 2 to 3%, and if you move to North America, it's up at about 1.4%. And in some countries, particularly on medical practices, for instance in Egypt, the rate can be up as high as 20%, but has fallen back now perhaps to 9 or 10% as the population has got older. Pakistan has a higher prevalence of around 5%, and many other countries in the rest of the developing world will have rates around 1%, but it depends on medical practices. In North America, Northern and Europe, the major drivers towards infection are in the use of intravenous drugs, and that's depending on the rates of those in the countries and the availability of needle and syringe provision and opiate substitution therapy, you can have very high rates in some special populations. So in Scotland, our OST patients, about 40% of them will have hepatitis C. People coming into prison, the rate of hepatitis C is about 10%, and those that have been formerly used drugs, some of them rates are suggested up at 80% or so if they're used in the days before widespread availability of needle and syringe provision.
What does a clinician need to know about the virology?
I think it's useful to look at the slide I've provided that shows the life cycle, so you can see the 7 points at which our drugs can interfere. And we have 3 targets at the moment, the NS5A inhibitors, the NS5B or the polymerase inhibitors, and the NS3 inhibitors or the protease inhibitors. And those 3 drug targets are what all our current therapeutic drugs are directed against. So knowing what those 3 proteins are and what they vaguely do is useful. So the NS3 protein, the protease, is the protein that breaks up the polypeptide from the Hep C viruses it's made into its component parts. The NS5A complex holds the virus together as it's being manufactured and made, and the NS5B copies the RNA to allow the hepatitis C virus to carry on replicating. And so those are the 3 things that you really need to know about. And other than that, you can bluff your way through. So the bluffer's guide to hepatitis C. And we also talk about resistant associated variants or RAVs, and those are mutations within those 3 proteins, or the RNA for those 3 proteins in the virus, and those are the mutations that will confer resistance to our drugs. So that's the other term you need to be aware of.
What about genotype?
So there is genotype 1 to 6, arguably you can have a 7th genotype as well, but we'll stick on the 6. From a Scottish perspective, we are predominantly genotype 1 and 3, about half and half, with about 5% genotype 2, and the 4, 5s and 6s are rare and usually have some exotic story of foreign travel and tattoos in faraway places to account for how you acquired them. The 3 genotypes are susceptible in different ways to the different drugs. We've had very great success with genotype 1 drugs in the last 2 or 3 years. This year we've seen pan-genotypic drugs appearing that take care of genotype 3. So genotype is going to be less important in our first run of treatment, I suspect, as we move towards pan-genotypic drugs. So as long as they're Hep C positive, we can treat them without knowing about their genotype. But at the moment, knowing whether they're genotype 1 or genotype 3 will direct your choice of therapy.
Untreated, what's the natural history of infection?
So hepatitis C is a slow, insidious virus. Most people who are infected with hepatitis C don't display overt symptoms, perhaps a mild flu-like illness. In the days when hepatitis C was transmitted by blood transfusion, when we called it non-A, non-B hepatitis, back before 1991 and the antibodies to identify it, only 20% of patients became jaundiced with their illness, and clearly that was with a whole unit of blood being transfused that was infected. And most of our patients are going to acquire the infection with a couple of microlitres of dried blood these days, so we don't see overt illness. So the virus focuses in the liver and slowly replicates over a time course of between 20 and 50 years. With alcohol as a cofactor, the process is accelerated, but you move through the stages of mild hepatitis, perhaps some fatty infiltration as well, and the development of progressive fibrosis. So about a third of patients will develop cirrhosis between 20 and 30 years after infection. About a third will take 30 to 50 years to develop cirrhosis, and a third will probably never develop cirrhosis in their lifetimes. Once you've developed cirrhosis, you then have a risk of developing hepatocellular carcinoma at the rate of between 3 and 5% per annum. So a substantial risk, and it seems to be more carcinogenic than other cirrhoses. So they're a particular case for screening those patients. And certainly we're seeing a rise in the number of patients with hepatocellular carcinoma, as our models predicted we'd see. The other thing to be concerned about is there are some reports appearing of hepatocellular carcinoma appearing in patients with hepatitis C without overt cirrhosis and at the stage of advanced fibrosis. Now, as you're aware as trainees, it is difficult to make a definitive diagnosis of cirrhosis, and it's rather artificial that a pathologist decides this is a lot of fibrosis, this is cirrhosis. And often if you've been to MDTs, it's whether they can see a whole round nodule or nearly a round nodule, etc. So I think it's those patients with advanced fibrosis or on the cusp of cirrhosis that we need to worry about. So I wouldn't get too upset about the literature in those areas.
And when a patient's referred to you with hepatitis C, what are the principles of initial assessment?
I think the first question is, do they want their hepatitis C treated? And that's, for many of the patients we deal with, that's a big question. I think you want to have a discussion with the patient as to what their symptoms might be and what they want done. We're in a phase that we'll talk about in a minute of having very effective treatments for hepatitis C. And the question then is not so much whether the patient wants treatment because of the side effects, because there are none. It's more about what's the benefits for them. So I think with the cost of the therapy, you want to ensure that the patient's motivated to move forward for therapy, that there's going to be some benefit for them. If the patient is 80 and has advanced terminal cancer, then treating their hepatitis C is relatively pointless. But clearly if they've got cirrhosis, it's progressive, and they have hepatitis C, stopping their virus could be life-saving, and so treating them is a priority. So those are the sorts of things you want to know about your patient. As we move towards other concepts like using hepatitis C treatment as prevention, which at the moment is a research question, then we'll be asking questions around what their current habits are with regard to injection drug use, whether there are no opiate substitution therapy or not, and how that might impact on their adherence to therapy, because if you don't take the tablets, you won't be cured. And it's now, rather than a safety issue that we used to worry about in the days of interferon, where we'd ask large numbers of questions about previous psychiatric problems, for risks of depression, problems with autoimmune disease, and problems with the bone marrow that we had to worry about with interferon. All of that is now irrelevant with the DAA drugs that we're able to use for hepatitis C. So it's become much more about ensuring adherence to therapy and that we can carry patients all the way through therapy.
What about staging their liver disease?
So in terms of choice of treatment, that's becoming much less important. There's still one or two classes of drugs that we would be less keen on giving to advanced liver disease, i.e. Child's B and Child's C, so those patients who are jaundiced, prolonged prothrombin times, low albumins, have ascites or have had encephalopathy, which is going to be relatively obvious to a skilled trainee in gastroenterology. Child's class A liver disease, which would be what you'd need a fibrosis marker for to diagnose, can be treated largely as it would for lesser stages of disease. So we need less staging. Staging is important in determining follow-up, So it isn't a barrier to starting treatment anymore. It's important in determining whether you discharge the patient once you've cured them or whether you follow them up long term for the risks of hepatocellular carcinoma. At the current time, there are some prioritisation issues around therapy, and so the degree of fibrosis is important in identifying who you can treat without restriction and who has to wait potentially for access to therapy. But those issues should resolve over the next year or two as drug costs come down, so they're not clinically driven priorities, they're cost-driven priorities.
Are you using then non-invasive methods rather than liver biopsy?
We would only use liver biopsy as a tool to look for other diagnoses if there was some dubiety about whether hepatitis C was the only illness. In terms of staging, there's the evolving field of minimally invasive blood-based markers. So the fibrosis 4 marker is based on available analytes now and is a cheap and effective test. And if you have a low value on that scoring system, you can be very confident your patient doesn't have cirrhosis or significant fibrosis. And if the value is elevated, you can then move on to more advanced staging techniques. Other panels that are becoming available, like the ELF panel, are still costly. They require the measurement of special analytes, but they're coming into their realm. FibroScan is very popular in Scotland. There's a lot of these machines available. Now that they're available, they are cheaper to run, but clearly there's an opportunity cost in getting them. They are not entirely accurate, but they give you again this estimate of what the stage is and whether you then need further information. So you're relatively certain that they have no fibrosis, a moderate amount or a significant amount. So those are the techniques that are available for us to stage disease.
And what general advice do you give patients about transmission risk?
So in everyday life, transmission rate is low. It's not particularly effectively transmitted sexually. So if you look at the haemophiliac population, transmission from the male partner to the female partner occurred in about 1 per 100 years of married sex. The risk may be higher in earlier relationships. I don't know what that says about the different types of relationships, but we'll draw a veil over that. It is very effectively transmitted by sharing needles and the paraphernalia associated with drug use. And so transmission rates are very high in that environment. And even in drug users who think they are following harm reduction measures and are not sharing but are injecting in the arena where other people are positive, we see a transmission rate of about 20% per annum. So it survives outside the body in dried blood for prolonged periods of time, and it can appear in the injecting water, the cookers, and the other swabs and paraphernalia that go with the needle and the syringe. So all of those factors are a risk for transmission.
Now, you've touched on this already, but how do you make decisions about who to treat?
So at the moment in Scotland, the focus is on treating those with patients with advanced fibrosis. Because of the cost of the drugs, there are limits on the budgets in health boards as to how many people can be treated per year. So everybody we know about with fibrosis should be treated straight away, and those with lesser stages of fibrosis should be treated within available budgets. At the moment, we're not prioritising patients with active drug use for treatment as prevention. That's the subject of clinical trials, but there's a lot of excitement around that area because that's the pathway towards elimination of the virus and therefore is cost effective. But we need more evidence before we move down that line. I think the challenge in terms of who we treat are the people that we are most in need of treating are the people we don't know about. To quote Donald Rumsfeld's, the known unknowns. So we know in Scotland about over 40% of our population who have hepatitis C are undiagnosed. They are predominantly the older, former drug users who have experimented a couple of times back in the 80s, who are now leading normal lives back in society with no marker on their medical records as to why they might be at risk of hepatitis C. And finding those people because they've had 30 years of infection and are therefore at risk of progressing to cirrhotic and carcinomatous liver disease is a big problem and a big challenge for us. And that's the group we should be identifying. And that's, over the coming years, is a group we're going to see a lot of work going into trying to find those patients before they present on acute medical takes for the varicose bleed.
Would you advocate screening?
So we've had long discussions in Scotland about screening. Our population prevalence makes it probably not cost effective to screen. And so we are below the prevalence rate for that to be effective. If we could find some other screening program that was already going on that we could bolt onto, that was a possibility. But hepatitis C is not evenly distributed across our population. It's very much a disease of deprivation. The last time we mapped it, some 95% of our known hepatitis C populations lived in 20 postcode districts in Scotland out of 167. So it is a very focused disease, and it's focused in those areas of deprivation. And so focused offering of a test within those areas may well be a possibility. It's twice as common in men as it is in women, and so that again would be a suggestion that we should focus more on men than women. But in this day and age, that's an unacceptable bias. So I think focused offering of tests to those at risk and focusing in perceived high risk areas, assuming that people don't move very much after their risk behaviours. And I think we need to look at other innovative techniques for trying to bring people who are infected into service.
Now, I realise that treatment regimes have evolved unrecognisably in a short period of time, but can you give us an idea of the drugs that you use and the combinations?
Okay, so the NS5B inhibitor is the key drug in many regimes. So the one that's most commonly available is sofosbuvir, which is a very powerful NS5B inhibitor and has a high genetic barrier to resistance. So that's a backbone drug. You can use that with an NS5A inhibitor like ledipasvir, declatesvir, ombitesvir, etc. And those are very effective combinations. And that will cure many patients. And the the NS5B is pan-genotypic, so it doesn't matter which genotype you use it against. The NS5As, some of them are selective, so ledipasvir is selective for genotype 1. Velpatasvir is pan-genotypic, so will cover all genotypes. And so that's a powerful combination. If you have a less powerful NS5B inhibitor, you then need to think about adding 3 drugs together. So the AbbVie regime of peretravir, ombitesvir and dasaprevir covers all 3 of those options. One easy thing to recognise is that the buvirs, sofosbuvir is NS5B, the Asvirs are the NS5A drugs, so ledipasvir, velpatasvir, etc. And the protease inhibitors, the NS3 inhibitors, are previrs, so boceprevir, talaprevir, cimeprevir, etc. So by looking at the end of the drug, you can work out which of the 3 it is that you're dealing with. And so you're really looking at a combination of NS5B inhibitors with an NS5A inhibitor, or all 3, or if you have a very powerful pan-genotypic protease inhibitor, you can combine that with an NS5A inhibitor. The real choice is that it depends which company owns which drug. And many of these drugs are now co-formulated into a single tablet, which is very important for adherence for many of our patient groups. And if you can have that co-formulation, then it's much easier just to take one pill once a day for 8 or 12 weeks and forget about it. So the classes of drugs are important to know. The individual drugs, it's more important what they're co-formulated with, because you can't access the individual drugs themselves in many cases.
Now, what factors influence your decision making about which regimes to use?
So in Scotland, we're governed by the Scottish guidelines, and we are cooperating across Scotland to try and bring drug costs down. So we've set a parameter that we will look and consider any drug regimes that achieve a sustained virological response rate, that's a cure, which we'll talk about more in a minute, of greater than 90% will be considered, provided they're SMC approved. The next parameter that will decide on which drugs you use will be cost, and so we will recommend from those guidelines which is the cheapest combination to use for the different types of patients, depending whether they're cirrhotic or not cirrhotic and which genotype they are. So whereas some of the pan-genotypic drugs, which we could just use to treat everybody, and i.e. you could have a one drug suits everybody in Scotland approach, by breaking it down into the individual classes, we can get cost pressures because some drugs have more limited success. So those guidelines are updated every 6 months or so and are available on the HPS website. And so you can look at them there and decide which is the most cost-effective drug for your group of patients. There are some drug-drug interactions that can be important for the choice of drug, and you can look at those on the Liverpool website, and the slides I provided give the web address of the Liverpool website, so you can look up for what their interactions with their medications. Patients who are treating for hepatitis C are going to have HIV medications, they're going to have medications related to their mental health, etc., and their cardiovascular risks as well, of which there are some interactions, and you may need to adjust dose or swap those drugs around. So that's the next level of decision, and clearly a drug-drug interaction for someone who is very stable on a difficult to control drug regime, it would be more important to change their hepatitis C drugs around to fit their existing drugs rather than change their drugs, particularly as the hep C therapy is only going to be for a short period of time. In terms of side effects with the modern DAAs, there's really very little to choose between them. We have no head-to-head studies that suggest that any one of them is better than any other, and so we don't regard that as a major factor in deciding choice of drug. Duration of therapy, there is a slight difference between the drugs at the moment. Some of them are for 8 weeks and some of them are for 12, and it's likely in the next year or two we'll have regimes that are available for 6 weeks. And if you have a special population that requires very short durations of therapy, for instance, patients who are in prison and have a short sentence, using the opportunity to complete therapy while they're in jail justifies using a short course of therapy, even if it happens to be more expensive than another choice. So that's how we make our choices at the moment across Scotland, and we all cooperate and work together to get as many patients as we can treated.
And what are the practicalities now of supporting patients through treatment?
So we have treatment services that were set up to get patients through interferon therapy, which was a huge, hard job for patients and fairly challenging for the physicians and nurses looking after it. So we have a network of nurses used to delivering intensive monitoring because it was a dangerous drug and required a lot of safety monitoring. With our new DAAs, if you're not using ribavirin as part of the regime, there is no real need to monitor patients through therapy at all. So you need a baseline blood test to confirm that they've got the virus, some liver tests to make sure that they don't have another liver disease. You can then start treatment. Some people like to do a PCR test at the end of therapy to see if they're virus negative at that stage, but that's more to monitor adherence to therapy than it is to monitor the effectiveness of the drugs. And then the key investigation is 12 weeks after the completion of therapy to check their HCV RNA by PCR, and that tells you if their virus is present or not, and if it's still negative 12 weeks after the end of therapy, they've achieved a sustained virological response, which we interpret as cure of the virus. And so we could be at the point of having a test at the very start and a test 12 weeks after they're finished, and that's probably all the monitoring you need. Locally, those practices will change more slowly, but that's the direction of travel. And it then allows us to look at different methods of delivering care. So in terms of focusing on who needs the support, and the support now becomes around adherence to medication rather than monitoring for safety. And how we monitor for adherence depends on which patient group we're dealing with. If you have a 55-year-old High Court judge who is discovered he's hep C positive and has got significant fibrosis, and you give him a tablet to take once a day for 8 weeks, he probably doesn't need any help in taking that medication. If you're trying to treat a 21-year-old active drug user who is just newly established on a methadone program, he needs huge amounts of support to adhere to his medication and to get his life sorted out, rather than safety monitoring. And so the role of our treatment support networks is going to change, more about bringing vulnerable, at-risk people into our treatment services rather than protecting them from the side effects of our medication.
What success rates are you seeing then in clinical practice?
So in clinical practice, we're replicating the randomised controlled trials in very chaotic patients. It has been a complete delight to have had patients on our books for many years who we have given successive unpleasant therapies to. I met someone in clinic yesterday who came out and gave me a hug, who I've known for 12 and a half years, having been through 3 courses of interferon with various add-ons that we've just cured with combined therapy. And he's now clear of the virus, and that whole shadow has been completely lifted from his life, and our conversations about the potential need for liver transplantation in the future, etc., are all now gone. So it is just one of the most exciting aspects that could ever happen to any physician in their lifetime, to have drugs this powerful that cure everybody, basically. We're probably left with about 3% of patients who we don't cure first time round with the new DAAs. About half of them probably didn't take their drugs properly, and about half of them will have interesting viral associated variant or resistance associated variants that will mean that they have to need interesting drug regimes. And so for the virologists, infectious diseases doctors, there's still a little bit of interest around the virus.
Are there any challenges left in hepatitis C?
I think the challenges are about identifying the patients with the virus. We have the power, we have very powerful tools on our hands. No one should die of hepatitis C unless we fail to find them before it's too late. So no one should develop hepatocellular carcinoma, no one should come in through the front door with variceal bleeding. We have medication that will prevent that from happening completely. But this virus is in the parts of our population who access our current healthcare systems least effectively. And that's the challenge as to how we reach out into those communities, find all the patients we need to find and cure them.
Well, all that's left really is for me to thank you for a fantastic update in what has been a dramatically changing subject. And thank you for joining us for Digest This.